welcome to our webinar, How Community Organisations Contribute to Healthy Ageing. So you have come to the right place. Hopefully you'll recognise that title. For those of you who don't know me, I'm Natalie Turner. I'm the Head of Localities at the Centre for Ageing Better. And I'm joined today by our panellists, Chris Dayson, Dawn Newsome and Emma Easton. And we'll be introducing them, or I'll be introducing them a little bit more later on. Just to let you know that we have a couple of colleagues at the Centre for Ageing Better, Joe and Millie, who are also going to introduce themselves in the chat, who've been very involved in the work we've been doing with Leeds Neighbourhood Network over the last couple of years. And so they may also be responding to questions in the chat throughout. Just some housekeeping notes before we start, to let you know that we're streaming this session live on Ageing Better's YouTube channel. So it will be available to view on demand immediately after we've finished. You're all live attendees are in listen only mode. So if you have questions for the panel, please post these using to us using the Q&A box, which you'll find in the control ribbon. It'll be at the top or bottom of your screen, depending on what view of Zoom that you have. We're going to be listening to our panel first, and then we'll be open for questions at the end. So again, use that Q&A box throughout as you hear things that occur to you. And also you're welcome to use the chat box for comments, responses, thoughts you have. And if you haven't already done so, as you've been invited to, do introduce yourself to others joining today's event. It's really great to see who's here and for other people to see who is here and where everyone is from. We do have closed captions today, which are available to all of you, and they can be turned on or off by pressing the CC button, which again is in the control ribbon on your screen. So a little bit more on today's webinar. Today, we're going to be exploring the role of community organisations or community-based organisations in supporting people as they age. And that's to achieve the kinds of outcomes and capabilities that we associate with good or healthy ageing. To help to do this, we're going to hear about the work of the Leeds Neighbourhood Networks. They're an example of community-based schemes that aim to address the social determinants of health, as well as promoting independence and well-being, and as well as some of the health-based partnerships with the community sector and how they can work. So a bit more succinctly than I have or could, we're going to start with a short animation that sets out what the Leeds Neighbourhood Networks do and how they work. And I'm sure you're going to recognise many of these features from community organisations you know or you work in or with. Over to our animation team.
A community that supports your health and basic needs is important when growing older. In Leeds, there is a group of organisations that aims to create just that. The Leeds Neighbourhood Network is made up of 37 community groups that provide a wide range of opportunities, activities and services. These include hobby groups, fitness and health classes, lunch clubs and day trips. The groups help members manage health issues, build relationships and encourage more physical activity. They also support people to be independent by improving confidence and building the foundations for healthy ageing. Being a member or volunteer of a neighbourhood network can help people's health through increasing social contact, improving mental health and well-being, promoting independence. By supporting people to make healthy choices around their health and well-being, neighbourhood networks can also reduce pressure on the health and care system, as well as on carers and families. To be as effective as possible, neighbourhood networks need to offer a range of activities that are tailored to the needs of the members, build strong relationships between volunteers and members and with other groups in the community, be responsive to members' needs and sensitive to these changes, and reassure members that the network will be there for them when needed. For neighbourhood networks to support healthy ageing, financial resources are also crucial. Neighbourhood networks in Leeds are grant funded by Leeds City Council to support people over 60 to be actively involved in their local communities and live independently. This core funding needs to be supplemented by other sources like fundraising. Groups also require accessible facilities, a strong leadership and workforce, good governance and a supportive policy environment. With an ageing population, neighbourhood networks are a vital tool in maintaining good health as we get older. Find out more about the Leeds Neighbourhood Network at aging-better.org.uk/Leeds.
Great, thank you for that. I'm sure, as I just said, I'm sure you'll recognise many of those features and success factors really in the community organisations you know and work with. So I'm going to start off, or our panel starts off today with Chris Dayson. Chris is an Associate Professor with the Centre for Regional and Economic Research at Sheffield Hallam University. Chris's research focuses on local and voluntary community action and the contribution it makes to health and well-being. So perfect for this. Chris will give an overview of the research findings from the Leeds Neighbourhood Network evaluation, which is this at the centre of our session today, and we'll be talking more about and around. Over to you, Chris.
Thank you, Natalie. Hello, everybody. Hopefully you can all hear me nicely and see my slides. So yeah, I'm going to give you a bit of an overview of the findings from our evaluation. This is the second of three phases of evaluation. And we've been focusing on healthy aging and the role that the networks play to contribute to that, but then also trying to use that as a way of thinking more broadly about how community organisations contribute to healthy aging. So first of all, let's start by thinking about what is healthy aging. And we started by using the WHO, the World Health Organization definition, which is the process of developing and maintaining the functional ability that enables well-being in older age. Functional ability is about the capabilities that enable all people to be and do what they have reason to value. And there's 5 components of this. There's meeting basic needs, learning, growing, making decisions, being mobile, building and maintaining relationships, and making a contribution to society. And through our work with the networks, we found that they do all 5 of these things in different ways, shapes and forms, but a lot of it is centered around supporting older people to build and maintain relationships in their community and in a way that enables them to contribute to society. So we wanted to place in doing the evaluation, we wanted to place healthy aging in a system context and make the link between individuals' functional ability, their physical and mental health, and biological age. So we explored 3 ways that healthy aging could benefit the healthcare system. And we call these kind of prevent, delay, reduce. So primary prevention of long-term conditions, delaying is about supporting people to manage long-term conditions to delay onset in severity that may impact on their health and well-being and kind of need for more acute care. And then reduce is about supporting people with intensive needs, including frail older people or people with long-term conditions, to relieve the pressure on the system. So that was the framework we used. Our methodology was what we would call a nested case study approach. So this was kind of a case study in 2 layers. So the first layer is the Leeds Neighbourhood Networks as a whole, providing a case study of how community organisations support healthy ageing. And we've reviewed a range of existing data and evidence to understand the wider context in which they operate. And then the second layer is 6 neighbourhood networks that we purposefully sampled and studied in depth. So we've undertaken 58 qualitative interviews with staff, volunteers, members, and wider stakeholders in those 6 networks. And we've also undertaken secondary analysis of other evidence that we've collected through earlier waves of the evaluation. So what we have now is this really large, rich, qualitative data set about how community organisations like the networks contribute to healthy ageing. So thinking first then about the outcomes, the healthy ageing outcomes along those prevent, delay, reduce criteria. So in terms of prevention, we found that prevention of ill health through community-based activities and support is absolutely at the core of the LNN model. They enable an increase in social contact, which reduces isolation and loneliness by giving older people opportunities to participate in a range of different social activities, enabling them to build relationships with their peers and other community members. This leads to an improvement in health and well-being. They provide structure and a sense of purpose to people's lives. And this also enables them to boost their confidence, their self-esteem, etc. And then they promote an increase in independence. So because of this wide range of activities that they offer, particularly those which kind of encourage mobility and kind of getting out and about, they help their members maintain and improve their independence, which again, it will in turn kind of prevent ill health and illness. In terms of delay, we found that the networks also help people to manage long-term conditions in order to delay illness severity and to kind of maintain a good quality of life. So one of the things they do really well is they identify when individuals' health declines, and they try and put the right support in place as quickly as possible. And they're able to do this much more responsively than, say, some statutory services. And this is because of the relationships that they develop with their members, which means they're in a unique position to spot those declines really quickly, intervene appropriately, and hopefully prevent the need for acute care in many cases. They also kind of support people to deal with and manage long-term health conditions on an ongoing basis, and this can help delay deterioration in frailty and other age-related illnesses such as dementia and cancer. And they often work hand in glove with other health services, so GPs and the health and the social care system as well, to support and educate their members about health conditions and how to manage them. In one example, there's a network working with local health services to deliver a course to support older people who are frail, suffering from memory loss, and needing kind of general help with their well-being, covering subjects such as healthy eating, mobility, relaxation, mindfulness, etc. So they give this kind of holistic, personalised support around health that really benefits older people. And then moving on to reduce, we found that the LNN approach can assist people who might have more significant support needs to reduce, and that helps them reduce the pressure on formal and informal care. So in terms of formal care, they're relieving pressure on the health and care system by kind of helping them maintain health and independence. This eases the burden on health services because they're giving information, advice. We found that many people are making fewer unnecessary calls and visits to GPs and hospitals. They also kind of have this kind of navigation role where they help people to navigate their wider health and care system, so that when they do make contact, it's with the right services in the right way at the right time, so it's more appropriate and efficient. But there's also the kind of the informal caring role that's really important in terms of healthy aging, and we found that what the networks do is relieve pressure on carers and their families. So they're lending support through things like respite care. And what this does is give the members, I guess, their families a sense of reassurance that loved ones are being looked after when they're not around. This was particularly the case during the pandemic, when lots of people couldn't see their families directly, but the networks were there giving that support and reassurance that family members couldn't do directly. So we're also interested in not just looking at outcomes, but understanding how change occurs, so that we can think about what are the implications of this for policy and practice. And we found, I think one of the things to emphasize here is that these healthy agings that we're talking about, they're interrelated and interdependent with complex causal pathways, which means they're really difficult to measure and understand kind of what causes particular outcomes to occur. We know that health is socially and economically determined, and individuals' contexts vary greatly around that. So this means that no member or volunteer of a network will experience the same set of outcomes in the same order or over the same time frame. So we want to understand these processes, and to do this, we've identified what we call 5 mechanisms of change, the 5 R's, and they help us understand how change occurs and how we might take the learning from this work forward more widely. So the 5 R's are resources. This is the financial and human resources that the networks receive from a range of sources. The range of activities they deliver, so those different those different services that support functional capability. The relationships between the networks and the members, between the members themselves, between members and volunteers, between the networks and their wider stakeholders are really, really important. Then there's their responsiveness to need. They have a really kind of tailored, personalised and responsive approach. And then there's the reassurance that they provide to members and their families that the support will be there. It's a constant in their lives. So we think that these mechanisms are what you might think about as the key ingredient of a healthy and thriving Leeds Neighbourhood Network, or a community organisation in general, really. But we also found that they're not necessarily present or distributed evenly across the network or the UK as a whole. So we think policymakers really need to consider how these ingredients can be fostered and developed further. So in terms of bringing all of the evidence together in a simple message, we've produced a simple diagram which kind of explains what do the networks do in terms of the work they do to support healthy aging, how they work, the range of activities, the relationship, the responsiveness, the reassurance, what they need in terms of resources and wider contextual factors, and then following through to the difference they make and the impact they have. I mean, hopefully that simple message will help convey the findings of this work to a wider audience. So just moving on to the policy implications to finish off, we think there's 4 ways to enhance how community organisations can contribute to healthy ageing. And I'll go through those in a little bit more detail now. So the first is the importance of primary prevention. We found that primary prevention is foundational to all that the networks do. It provides a vital contribution to the social determinants of health, but it also provides the basis for kind of secondary prevention when this is necessary and appropriate. So we think it's really important to ensure that community organisations are resourced to undertake this primary prevention, even though the way the current healthcare system in particular is configured means that demand for secondary prevention or reactive support is going to increase in the future. We still need to maintain that focus on prevention alongside that. The next is around the value of long-term core funding. So this has been absolutely vital in enabling the networks to develop and sustain their service over an extended period. And it provides a platform for other human and financial resources to be levered in and enhance the work. So we've estimated that at least for every £1 that Leeds City Council invests in the networks, they bring in another £1.50 into the city, and it's probably greater than that. So we think anyone seeking to involve community organisations in their support offer should provide that core flexible funding wherever possible. And we should think about this as good and effective commissioning practice. It shouldn't be seen as a kind of a rarity. It should be the norm. So we need to enable community organisations to thrive, but it's about more than resources. We recognise that community organisations require a number of capabilities and capacities in order to enable them to operate in a way that's sustainable and effective. We think the 5 R's that we've identified in this research are the key ingredients of a healthy and thriving community organisation. So policy needs to be developed to promote these and support their development. And this is how the contribution of community organisations to healthy ageing is going to be enhanced. The final one is just around, I'm sorry, you couldn't get away with having a presentation without the words levelling up in it, but we think there's a need to level up support at a neighbourhood level. We know that those 5 R's aren't distributed evenly across the Leeds Neighbourhood Network, and we suspect that inequity in the support available from community organisations is likely to be replicated across the country. So not everybody has access to the same level and type of support. So we need to think about how can this be levelled up to ensure equity of access and outcome for older people wherever they happen to live. So we are moving into the final phase of the evaluation, and what we wanted to do through that was pick up this equity point. So the kind of overarching question for this final phase is, how do we ensure equity of provision in community-based support for older people to enable them to age actively and healthily? And within that, we're looking at equity in 3 ways. We're looking in terms of equity of offer, so the range of services that are being provided, equity of access, who's able to access those services, and equity of resources. And we hope that by exploring those types of equity across the Leeds Neighbourhood Network, we'll be able to provide some really important evidence for the City of Leeds, but also for the kind of the wider UK policy environment as well. That's the end of my presentation. I think it's important I kind of acknowledge that this is a massive team effort. There's a research team from Sheffield Hallam and also University of Birmingham and We Research It who played a massive role in this, and also the partners from Leeds and from Aging Better, because this has been a real kind of, I guess, a joint effort to get the research to where it is now. Oh, and then finally, obviously, kind of we couldn't do it without the networks themselves who have been really engaged and supportive over the last few years as we've done this research. Thank you.
Thank you so much, Chris. Really, really interesting. If, like me, you were fascinated by a lot of the detail on what's actually a really helpful framework, the slides have gone out with the report and will be available as well, so you can use that in more detail. Thank you very much. And talking about not having been able to do it without the Leeds Neighbourhood Network organisations themselves, moving on to Dawn Newsome, who is the Chief Executive of Army Helping Hands, one of those neighbourhood network schemes in Leeds. Dawn's been working with the organisations for over 25 years and so is absolutely brilliantly placed to tell us in a bit more detail the work of Armley Helping Hands and what they do to ensure people in their communities are maintaining their wellbeing. Please, again, do post them any questions you have when listening to presenters. Just pop it into the Q&A again. Over to you, Dawn.
Good morning, everyone. I'm Dawn Newsom and I'm the CEO of Armley Helping Hands. We was phase 2 of the Neighbourhood Network set up in Leeds, where we was established in June 1995. I think fundamentally for all the neighbourhood networks, the key delivery in establishing the neighbourhood networks has been that consultation with our older people. They have been the voice from the development of the neighbourhood networks and continue on our steering committees and our board of trustees to identify the needs in their area. Significantly, the neighbourhood networks are bespoke to our community. We all have the same objectives and outcomes, but we deliver services to the needs to our older people in our area, which is fundamental because across the city, there's significant changes and demands, and it enables us to actually pinpoint what's needed within our community, what are the struggling barriers that our older people are facing on day to day. There's 2 tiers of the neighbourhood networks. From the video, you clearly saw that it talks about social interactions, social engagement, delivering activities and services, and we all do that. And that is one way of reducing socialisation, improving a healthier lifestyle for our older people, and making sure that older people engage with friends and family and their community. But there's what I call behind the door work, which many people don't pick up, that we do. And this is the intense support and intervention we work with individual older people within the home, within their community. We're a service that never dips out. From the initial point of contact, we will continue providing support, intervention, and being an advocate for that older person right through to end of life. And many times after bereavement, we continue to support family, spouses, to enable them to maintain their independence and deal with day-to-day situations. This is a key part of our work as we are a catalyst to services. We have strong working relationships with our GPs, our social workers, our intermediate care teams, and our community partners to make sure that we can be the gateway services for older people. We don't just signpost older people, we follow them through them pathways and help them to be there and to access the services when needed. Fundamentally, we are the advocate. We encourage older people to have that early intervention, particularly around health and wellbeing. We flag up at early stages of symptoms and encourage older people to access health and social care rather than waiting to crisis point, where fundamentally the older person's choice is taken out of their hands. We try and make sure that the older person has as much control as possible to maintain their independence within the community, to enable them to continue that transition in their retirement years to the choice they want. You know, many of our older people will say they feel at times their lives taken over by statutory services, family members. And we're there to say, right, let's take a step back. What is it you want in life? We will help you to our best potential to do that. And fundamentally, that is one of the strengths of the neighbourhood networks. We work with our community, we work with our older people, we work with the family and the bigger nucleus. We have to work with that the whole family to address the needs of our older person. We're going forward, we're also seeing significant changes in our older people. The younger generation coming into our services have fundamentally got more complex needs, high levels of mental health, high levels of social anxiety, high levels of social issues, family issues. So we're always having to readapt our services and support those individuals. Like my colleagues across the city, we are unique and we're proud to be neighbourhood networks and support the community.
Thank you, Dawn. That was fantastic. I'm really struck by your point, your opening point there. We signpost. We don't signpost, we follow people through, which really speaks to that relationship and responsiveness that was being discussed by Chris. Thank you for that. There'll be opportunities to hear more from Dawn next, but slightly moving away from that now, the next speaker that we have Coming up is Emma Easton. Let me just get my, I've got to get Emma's bio up for a moment. So yeah, Emma Easton, she's the Deputy Director of NHS England's Voluntary Partnerships team. So Emma leads on developing more inclusive partnerships between health, the voluntary community and social enterprises, and is going to talk about that now. So that's sort of, we've gone from the detail to a little bit more of an overview about what this looks like across the country. So over to you, Emma.
Sorry, I'm just having issues with all my buttons. None of them would work. Thank you so much for inviting me today. And my name's Emma Easton, and I work at NHS England and have done for nearly 10 years now. In that time working on how we can improve partnerships between the voluntary sector and the NHS and vice versa. So I wanted to start by, I suppose, talking about why and what is it that's so important. And I suppose I was reflecting on this and thinking about the fact that obviously we know that the NHS was set up for a very different purpose to the one it has today. Now, the long-term plan ambitions, which is the strategy that governs the NHS's direction, which was published a few years ago now, has 3 overarching ambitions, which are making sure that everyone gets the best start in life, delivering world-class care for major health problems, and supporting people to age well. And all of those things really speak to the voluntary sector. So the voluntary sector has always, in the voluntary and community sector, has always been absolutely integral to the way that the NHS operates. And of course, the NHS was founded on voluntary endeavour. But it's never been as important as it is now, because there's no way that we can achieve those ambitions that are set out in the long-term plan without those partnerships with the sector and without doing things in a different way. And I suppose the last 2 years have really shone a spotlight on this. I can't really do any presentation anymore without mentioning the COVID word, but it really has shone that spotlight on the importance of the relationships that we have with the voluntary and community sector. It obviously provides routes into communities and helping to reach people that the NHS can't reach by itself, and helping to tackle health inequalities in that way. We also rely on the sector, and we do rely on it to tell us about what's impacting communities at any given time. And if I think back to the start of the pandemic, we were hearing lots of stories about the way that things were affecting communities in ways that we hadn't necessarily envisaged, because nobody had envisaged it. And so we really need to keep hearing that kind of that voice and influence, both strategically, nationally, and also locally and for individuals. And clearly the voluntary sector and community sector is important partners in delivery, and some of what we've heard so far really shines that, has that come through around how important those delivery partners are. And then I suppose finally on the kind of what it is, actually there was something that Dawn just said about the adapting services to need that the voluntary sector does so well. The speed of response, if something happens in this country and it affects a particular community, it's always the voluntary community and faith sector that respond first and really well. And so we absolutely need to draw on those partnerships. And then something that our Director of Health Inequalities stresses a lot when she speaks is that it's not what the message is a lot of the time, but it's who delivers it. And sometimes you do need in front of you somebody in a uniform, and you need somebody who's going to help make you better. But the rest of the time, you need somebody who's going to help you live well. And that has to come from somewhere else. It doesn't necessarily come from somebody in a uniform. It can do sometimes, but it needs volunteers, it needs parent champions, it needs advocates, and all of the different people that operate within the voluntary sector environment to help get the messages across in the way that they need to be delivered. So to go back to that long-term plan that I mentioned from a few years ago, the original commitment that was in there about how we would work with the voluntary sector talks about the fact that we will continue to commission, partner and champion the sector in the work that they do to support vulnerable and at-risk groups. This year, later on this year, there will be a refresh of that, taking into account the pandemic and what needs to happen next. And my strong suspicion, but it hasn't been written yet, is that there will be an increased focus on the role of the sector, and it will be more than just that sentence, because it's so important. And I think that's really being recognised, and I hope that you can see that in the work that you're doing. And part of the things that have changed is that we've actually now got these systems called ICSs, integrated care systems, integrated care boards. We've got a whole new set of jargon that we use, but that's really about trying to integrate everything to do with health and social care at a more localised level, working with systems, which is quite a large area, through to place, through to neighbourhoods with primary care networks. And everything that's being done in that is to try and create that better partnership working, recognising that more holistic need that we have. So within, if anybody's actually read the ICS design framework, it's a very thrilling read, but it really talks about that importance of having a formal agreement, I think possibly for the first time in this way, to engage and embed the sector in how we're working. And to support that, we've put in place a VCSE alliance in every system. And if you don't know who is involved in your VCSE alliance, it's worth finding out, because that is essentially a way of trying to make it a bit easier to navigate. It's really hard for the sector to know who to speak to within the health and care system. And equally, it's really hard for the health and care system to know who to speak to in the sector. And so those alliances are trying to provide that bit of a single point of contact to try and make that easier. And I suppose within that, it's a real desire to reframe some of the challenges to mean that we're trying to find solutions together. There's also a load of work we're doing nationally, but I'm not going to go into that in too much detail because I think it's more important that we focus on the local. So I will finish there and pass back to Natalie.
Thank you very much, Emma. That's really helpful. Broader overview, especially bringing in some of the system changes that are going to be helpful, or so hopefully helpful, but certainly going to impact on local community-based organisations in this space. So we've had a few questions in the chat, and I'm going to just put them to the panel. I wonder, Emma, Chris and Dawn, if you would like to come onto camera. I mean, we can see if we can cover these together. But there is there is one question, which seems to have disappeared off my screen actually. Was there? Maybe I've accidentally clicked that I've answered. Essentially, it was quite a long and really thought out question on inequalities, I think, basically about, and I know that some of that is going to be addressed, Chris, in the next phase of the evaluation. I wonder if each of you could maybe talk a little bit about, maybe Dawn, with the impacts of the differences you started to talk about the next generation, Chris, yourself, what you're seeing in them, what you think are the key issues, and Emma, about those kind of inequalities in access, in education, in advantage and disadvantage, and how that impacts on the way community organisations can take a role in this work. So maybe Chris, if I could start with you and then pick up with Dawn after that. Sorry.
Yeah, I think we think it's a really important issue to grapple with. And it's quite a difficult one to grapple with from a research perspective, because we're trying to map lots of different things. But I think what we really want to understand is kind of, are there some contexts, organizational contexts and kind of neighborhood contexts that combine to kind of help or hinder when it comes to inequity? And are the areas that are I guess worse affected by health inequalities and social inequality? Do they have a better or worse offer in terms of community-based support? It's a tricky thing to piece together, but we think it's really important. So we're in the middle now, trying to kind of build a framework to kind of understand how we might look at that quantitatively and qualitatively to try and shed some light on it. And I don't think it's about saying everybody in every area should have access to exactly the same thing. I think it's about trying to understand is there a minimum level of support that we think is needed, and how do we go about trying to address that, and what's the role of commissioning, what's the role of partnership working, things like that. So it's a really important issue, and I think it kind of strikes at the core of I guess the integrated care system agenda. So ideally we want integrated care systems to work in a way that enables that inequality of provision to be addressed. And I think it'll be an interesting few years to see how that comes about. And I suspect some areas will do better than others in terms of the integrated care systems and their engagement with the voluntary sector. And it will be about, can different areas learn from what other areas are doing in terms of involving the sector in health.
Great, thank you. Chris, and yeah, we've got a couple of questions on how other places can learn from all of this. But Dawn, I wonder if you were able to come in on that question around inequalities.
Yeah, I've just shared on the chat. So Armley Up Nans has just finished a 4-year programme called Don't Call Me Old, which engaged with 50 to 70-year-olds. And significantly, we have learned from that programme about the barriers those people face in approaching retirement life, particularly, as somebody said in the chat, about the increase of pension age. We're seeing people with high levels of long-term conditions, mental health problems, where they cannot continue working to the retirement age, and they feel they're in a little bit of a loophole because they're not identified as elderly, so they can't automatically go into those older people's services support, and they're still having to deal with the day-to-day, like GSA, etc. So it significantly is a age bracket that we need to readapt our services. We need to be able to put that early intervention, that pre-retirement support work, so that we don't wait until they get to retirement age and at crisis.
That's great advice. Thank you, Dawn. Emma, is there anything you'd like to add to?
Yeah, I was just thinking that I talk about the pandemic a lot because it's all I've worked on for the last 2 years. But through the NHS Volunteer Responders programme that was established to provide, it was essentially established to provide backup supports to community organisations. And what we've seen through the last 2 years is that there's almost a linear relationship between the number of people who've needed help in areas of deprivation and the number of people who've needed help in areas of affluence. And my suspicion, but I don't have the data to back this up on the other side, is actually that has almost a complete opposite relationship to the amount of support that's actually available in those areas locally. And what we also see when we have, I suppose, funding applications for different pieces of work is quite often we get some fantastic applications through from organisations that work in areas of deprivation, but they are competing against organisations that have the bid writers and things against them. And so actually it's not just a question of, I suppose, us saying, right, we want to do more around those areas of deprivation. We've got to do even more to try and work with those organisations to, I suppose, to speak some of the same language that we're talking about. And I'm not saying that people need to start speaking the NHS's language by any means, but actually more proactive helping to frame things in a way that helps people to get the support that they need.
Interesting. Are you suggesting there might be a role for ICSs to bridge that gap? Or
I think so, yes. Yeah, I think definitely.
Great, thank you. That's really helpful. This is quite a pivot, this next question, but and also I think that there might be people who are in the webinar who've got answers as well, could put this in the chat. But it's actually the role of sports organisations in Leeds, but in this community organised. How is it, especially people who played sports over their career? I know we had this prior to the webinar starting. Any thoughts on what you've seen and done either locally or nationally?
I don't. Sorry, no, Dawn, you go, because I think you probably got more first.
Yeah, I mean, especially ironically over the pandemic, we're finding sport providers like Leeds United and Leeds Rhino want to invest more in working with people within the community to integrate people into sport and activity. We personally are just going to start a Fit Generation programme with Leeds United, delivering bespoke exercise programmes to our older people in sheltered housing. And fundamentally, it's important to fetch them health and wellbeing and opportunities to access to our leisure facilities, sport facilities, and reduce those age brackets. So make everybody aware that the activities for all ages, not just for young people.
Thanks, Dawn. Chris?
Yeah, I was going to make a similar point, but I think kind of Dawn I guess talked about, gave a really specific example, but I think there's a wider point around we need to think about organisations like the Leeds Neighbourhood Networks not in isolation, but as part of an ecosystem of different types of providers. And those ecosystems are going to look different in different places. And it's about how do we make sure that the connections are made within that ecosystem so that providers are linked up and they have the pathways to make sure that people can engage in multiple organisations in different ways, in the ways that kind of matter to them. I think that's what's really important. It's the joining up of all the different provision to make sure that people can access a whole range of support. So in one area, it might be appropriate for an organisation like a Leeds Neighbourhood Network to provide a particular service, but in another neighbourhood that might be provided by another organisation, and that's okay as long as the links are there between the two organisations to make sure that patients and people in the community can access both of those.
Thanks, Chris. I'm going to move on to another question, which is that there's a couple that are a bit linked, I think, really, but that one around the Leeds Neighbourhood Networks. To what extent are they a product of their history and current? Sorry, there we go. Let me just get that right. To what extent are they a part of their history, and can they be replicated elsewhere? I think, Chris, you've tried, particularly with your framework, to kind of give us a sense of how they could be moved elsewhere. And it'd be great if Emma sees anything in the work we've talked about today that she thinks that other lessons could be drawn to other places. And Dawn, I'll come to you last, if that's okay. Chris.
Yeah, I think the voluntary sector in every single place in the country is a product of the kind of the rich cultural, social, economic histories that exist in that place. So you're right, it's not about saying kind of supplanting one model from one area and putting it in another area, which is why we try to come up with those kind of those common principles. And it feels like sometimes boiling it down to kind of some small number of words all beginning with the same letter can feel quite trite, can't it? But we wanted to try and think about a way of making some of those principles useful. But of all of those, I think the most important is relationships, and kind of relationships in every direction. And I think where we see strong relationships between organisations and strong relationships between individuals within organisations and outside of organisations, that's where you get really good and effective kind of voluntary and community sector support in partnership with the public sector. So I think that those relationships are really important. But often time to build those relationships is a thing that's missing from people's everyday work. And I think it's about realising that building those relationships is a really key part of the work, and it's okay to prioritise that sometimes.
Great, thanks, Chris. And I know the research has particularly emphasised, and I know this is not easy from place to place and hasn't been easy, the long-term nature of the funding and the relationship. So whatever that is, that sense of being able to allow those relationships to establish over time is quite key, isn't it? So there's something for commissioning in there. Emma, thoughts?
Yeah, I think to me, the voluntary and community sector is delightfully messy. In a really good way, in that actually in every area of the country you go to, organisations have sprung up in response to unmet need. And the unmet need is different in every part of the country, naturally. And so there will be huge variation in the way that different organisations operate and have evolved and have established themselves. What that then leaves, though, is a bit of a challenge for us, because what the NHS would like is a nice, easy way of trying to find who those organisations are in a nice structure. And it's even as simple as, I suppose, trying to find sort of, well, we know that this is going to benefit people. Does this organisation even exist in our area? And if it does, are people even calling it the same thing? So that's part of our challenge, I guess. And it's one of the reasons why, when I was talking before about the VCSE alliances that we've established, is to try and help create that route through to finding people. Because whilst a lot of those routes have existed before at place level, and even in neighbourhood level, people know how to find organisations. But as you actually start changing how the structure of geographies work, so for example, for Leeds, that's within the West Yorkshire and Harrogate system, and I don't know of a single voluntary sector organisation that covers the entirety of West Yorkshire and Harrogate, and therefore there needs to be some kind of structure in place to help with that, but without losing the fact that the sector is delightfully messy underneath.
Yeah, thank you. I've heard that many times, that sort of like simplicity versus the complexity that's helpful. Dawn, have you got any thoughts about sitting where you are? Do you feel specifically lucky for coming in Leeds, or do you think that other places can do this work or can learn from this, and how?
From my experience, I've obviously been involved in many research, etc., over the years, and being the voice of the neighbourhood networks. I think we are quite unique in Leeds, but at the same time, I think we've still always got an open door of developing and learning new methods of way. As I've already said, it's about supporting our people. I think fundamentally for us in Leeds is about our community and connections and engagements. I personally feel that, you know, we have got a strong working relationship with our community partners, especially NHS and adult social care. And fundamentally, that is one of the strengths of the neighbourhood networks. You know, I speak to third sector organisations within Leeds and across the country who don't have them relationships. I speak to NHS staff who don't speak to senior management or have the opportunity to raise their views and opinions about what's happening on the ground. But we have that opportunity, and I think that's fundamental. That one of my roles can be is that I can be a voice, not just for our older people, but for my colleagues within the community, and raise that awareness that strategically up there, it might show we need this service, but to be honest, on the ground, this is what we need to develop.
So is that something, if you were to start a Harmony Helping Hands somewhere in a completely different part of the country and start from scratch, is there one thing that you would start with then? Is that it?
As well as knocking on my older people's doors and community organisations, fundamentally I've been knocking on the GP's door, on the social worker's door, and in the intermediate care, and saying, right, collectively, how can we work together to meet the needs of our older people? And that's what we do here. You know, we work collectively with our partners and ask them. So we don't put just a funding application in saying this is what we want to do. We consult with our key partners, and that also strengthens that relationship because they feel they've had a view and opinion on the way we work.
Brilliant, thanks, Dawn. I've got a question here around housing associations, and apparently a bit of a lively chat in the conversation about whether that could be considered voluntary sector or not. And I know we're talking about community-based organisations, and some are, some aren't. I'd be really interested in what the relationship is with housing associations in Leeds, and also, Chris, what your observations, whether from this work or elsewhere.
It's probably worth the kind of, sometimes the devil's in the detail, isn't it? So if you look into the detail of the neighbourhood networks, what you'll find is that some of them are actually run by housing providers. So Methodist Homes, which is one of the biggest care home providers in the country, actually runs 3 neighbourhood networks, I think. So there is a really strong link already with housing providers, and I think individual networks, Dawn can probably say more, have relationships with the social housing providers in the area. So I think they are absolutely part of the picture. I think there is a debate about where do they sit, where do housing associations sit sector-wise. I think which sector they're in doesn't really matter, as if the connections and the relationships and the partnerships exist at a community level to benefit people that need support.
Oh, thank you. Dawn or Emma, anything to add to that? No, great. I just wanted to draw people's attention. So Benita, who's part of the Birmingham Neighbourhood Networks, which is already one effort to kind of at least take the concept of the neighbourhood networks and start them in a different place with a different context, has already put some notes in the chat about the learning that they've had, and maybe we'll get her back at some point for a future webinar. Sarah Wilkinson has put in the Q&A about the tension between providing services, commissioning services locally and meeting with maybe more dispersed communities across a wider area, like the deaf community or BME communities, people who consider themselves a community but aren't actually located in a specific geographical place. Who would like to answer that from the panel?
I mean, I can say that is very much the focus of what we're trying to explore in the next phase of when we talk about equity of access. We're saying we want to really understand, are the networks supporting a diverse population that's broadly reflective of the neighbourhood they live in, or are they just for a certain demographic? And I think we need to understand that. We need to dig into the data a little bit more to understand that, and then look at where it does vary. Why is that the case, and what is the learning that can be taken from where they have been able to reach that broad degree? But I think it's a tension. I think the tension between targeted and universal vision is a tension of across kind of community-based approaches, isn't it?
Definitely. Emma, I saw you unmute first, and so you first and then Dawn.
Yeah, I think, again, if I think about the way that we're trying to structure the health and care system, in theory, it provides an opportunity to commission services at the level that's most appropriate for people. Now that remains to be seen, but in theory it does. But there's already, I suppose, that happens in clinical world, in that there are some conditions that are quite rare, and therefore it doesn't make sense to commission a service at a local level for 1 or 2 people, and it does need to be done in a different way. The importance, I suppose, around all of this is the co-production element, isn't it? And that actually we need to be really making sure that we're hearing from those communities about what it is that they actually want, and making sure that there's that really focused effort on it.
Thanks, Emma. Dawn.
Yeah, just on what Emma was saying, it's about being co-productive and working with the individual. So we, like I said earlier, about being a gateway, we can offer that older person to access our services as a whole community, but also make sure that they've got the resource and information about more citywide initiatives, national initiatives that support them for their individual disabilities. And that is fundamental, because we can see it the other way, where we find that if they're just directed prominently to, like, say, Deaf Association, they can then become quite institutionalized in just one network. So our aim is to sort of spread their wings and enable them to go into different levels and different parts of the community, not just focus on their health.
Yeah, that's really helpful. And I think that speaks to one of the other questions or points that were made around differences within communities, not just between places, and then being able to respond to those kinds of subtleties in our kind of population and what we need. That's really helpful. We have another question around inequalities, but I'm just thinking, is there any other specific one that anybody has seen that they want to pick up? There's one here around the corporate social responsibility programs and supporting these kind of community-based approaches. And we talked a little bit about kind of, the resources and the £1.50 or at least that comes in from other sources. Dawn, I can see you sort of nodding at that one. Any thoughts about how the private sector has been or should be more engaged with?
Yes, we've had a 20-year relationship with Premier Farnell, which is an international electrical company. They store our vehicles and they offer us HR support, which has a mass cost recovery for Armley Helping Hands. Just the minibus storage alone is 15,500 and 2,000 reduction on our insurance, because they're actually in HMO regulation sites. That's also given benefits to their employees. They actually seen a reduction of staff who engage with us, maybe because they've returned to work, etc., because of issues, reduced sickness levels, and particularly in the pandemic, they supported us and our neighbourhood networks by distributing 50,000 face masks across the country, city. So we do work with big companies and small local companies. We emphasize on using small companies as that, like our IT support. So again, fetching that investment into community, and we get that more personalized service because they know that they're supporting a local organization as well. So yes, as well as statutory, private sector is important to us as well.
There's a real rich mix that's needed of resource and support from the whole community, isn't it, to keep these going? So I'm really conscious that we're moving quickly towards the end of our time here today, so I should wrap up. Just want to ask each of the panelists whether there's anything they want to add or respond or say before we close up. And I thank you. Chris?
I guess just to say this project, I guess, is kind of unique in terms of a research project, because it is very much a kind of a co-produced effort between the research team, Centre for Ageing Better, Leeds City Council, the networks, other partners. I think just it provides a really good model of how to do research, and I think we've been able to do things like this is really important, and enables us to shed the light on the work of organisations like the networks, but in a way that hopefully is much more impactful for policy and practice. So just, I guess, thanks to everyone for kind of engaging and continue to engage in what's been a really rich, impactful project for us.
Thank you, Chris. Emma?
I think possibly just to echo what Chris has just said, thank you so much. It's been really interesting to listen to today, and to hear, and to specifically, as Chris just said, the value add of working across all those different sectors and with all those different participants really shines through. So thank you so much.
Great, thanks. Hope we've come up with a framework that will be useful to you and colleagues and what you're looking for. Dawn, definitely not least, but last, any thoughts?
I think fundamentally it's about sustainability. One thing that has not been mentioned in this webinar is that, yes, we're doing great work, and I can see a lot of commissioning officers, etc., but we need long-term investment. Our work is not short-term. As I said, our work is the longevity of that older person's retirement years. We're not a service that dips out after 6 weeks, after discharge. We continue providing that intervention, and fundamentally for myself, my colleagues on this webinar and across the country, sustainability in the third sector is fundamental. We don't need the 12 months, the 6 months for investment. We need the 5-year investment so we can really be productive in our community and help our statutory providers really meet the key targets.
That's a really great call and well made. Thank you, Dawn. I really appreciate that. And something else I took from what you were saying earlier about working earlier, 50 to 70-year-olds, and thinking about getting people before they reach crisis point. That's also something that's close to our heart at the Centre for Ageing Better. I hope you'll not agree. It's been a really rich and thought-provoking discussion, and I honestly, we could have sat around, and if we were in person, we would have sat around chatting all day, definitely. But please, could you pop in, take a few moments to give us your thoughts about this webinar. A link to give your feedback is in the chat. And this webinar will also be available to watch on demand, as well as the slides that Chris provided and the report for the phase 2. And as this is phase 2, there is another phase to go, and we really hope you all can come and join us for future sessions when we hear the whole extent of the evaluation work we've done with Leeds. Thank you again, and thanks to the panelists again, and for your time, for all of you joining us today. I know it's precious and